Cool. So welcome everybody to this webinar for the latest HIV prevention treatment news from the Conference of Retroviruses and Opportunistic Infections of 2023. We're joined by Roger and Gus from NAM aidsmap today, who are going to go through the presentation on the information shortly. The layout of today's presentation is that the first half is going to focus on covering antibiotics to prevent STIs, because that was a large section of the conference. And then the second half will focus on the other topics that were covered. We'll cover comments and questions in the Q&A box halfway through after the antibiotics discussion and then at the end of the session. So feel free to be posting your questions and comments as we go along, but we'll get to them in those two separate sections. And just to inform you all that the slides from today's events will be shared after the event. So Roger and Gus, I will hand over to you and I will start sharing the slides as well.
Great, thank you, Brogan. So just as a really quick introduction, I think obviously the big conference that always happens every summer is very well known, but CROI is kind of where a lot of the scientists, particularly the American scientists, really like to meet each other, and it's often where some of the really important data is presented. And this year in particular, there was this big focus on using antibiotics, doxycycline, to prevent STIs, which has obviously got big implications for sexual health and how this is managed. So Gus is going to start on some of those studies, and then I'll pick up on some of the other ones, and then we'll really encourage. I'd really be interested to hear what you guys think and what else you'd like to know about, you know, particularly how applicable this stuff is going to be in the UK. So Gus, thank you.
Okay. Next slide, please. Thank you. Just one question. I see there's already something popped up in Q&A. Is that how people are going to be asking questions? Yeah?
That's right, Brogan, yeah?
It is, yeah, but we'll answer them halfway through after the first topic and
That's
then
right.
at the end, yeah.
I just wanted to put that in. Anyway, using antibiotics to prevent sexually transmitted infections. Well, I mean, when I sort of do the background research, sometimes sort of certain facts surprise me, even though they shouldn't. I should know them. The fact that surprised me this time was really how prevalent STIs are in gay and bisexual men, particularly, specifically. As you see from the right-hand slide, that shows how the bacterial STIs, chlamydia, gonorrhea, syphilis, continue really to increase. That's only up to 2017, but I assure you that the rates are still increasing up above them. The rate for syphilis is actually 5 times lower than that, the rates for the others. There's 2 different axes, but nonetheless, there's been continued increases in these. The surprise I remember I got when I looked at the lower left picture. That's the increases split between positive and negative gay men and heterosexual people, men and women. But if you look at the 2 axes there, you can see that the rates in gay men are about 100 times what they are in heterosexuals. So the left-hand axis is the rate in gay men. The right-hand axis is the rate in heterosexuals, right? And so about 100 times that rate in HIV negative gay men, and about 200 times that rate in HIV positive gay men. So it's a problem that needs addressing for simple health reasons, and you don't want these things. Syphilis is still potentially a very serious infection, particularly, and so can gonorrhea be. Anyway, next slide. Okay, this is not, it's not the first time that this has been tried. The first study that happened in Los Angeles in 2015, small pilot study, 30 gay and bisexual men were given the antibiotic doxycycline, and 30 basically not. They were given financial incentives to avoid STIs. Clearly didn't work, even though they were quite generous, up to $100 if they stayed STI free. And overall, there were 73 fewer STIs in men given daily doxy prep. So that's taking it every day, regardless of what you're going to do in the evening. Next study was the French study in the participants from the IPA PrEP study, which you may know about. And 106 of those were randomized to either take doxycycline PEP post-exposure. That means no more than 72 hours after exposure, whereas in practice, most of them took it less than 24 hours after exposure, versus no PEP. So the overall efficacy in preventing all 3 STIs there was 47%. But that was split between 70% efficacy against chlamydia, 73% efficacy against syphilis, but only 16% against gonorrhea, and that wasn't significant. In other words, that could have been a chance result. The efficacy might have been 0. So we're seeing a split between clearly good efficacy against chlamydia and syphilis, but either none or reduced efficacy against gonorrhea. Okay. Then in 2022, the DoxyPEP study, again, a larger study in Seattle and San Francisco. This is the one with the graphic on the right. 501 gay and bisexual men, and they were split this time into positive and negative gay men, were randomized to DoxyPEP versus no PEP, 66% overall efficacy. Again, excellent efficacy versus chlamydia and syphilis. The reason that it was slightly lower was not because it was actually in positive men, was not because it was actually less effective, but because actually the positive men in the standard of care arm without the PEP actually caught rather fewer STIs. So there was less dramatic difference. And there was efficacy against gonorrhea. It was considerably lower at 55% in the negative men, but it was there. So we're seeing this pattern of reduced or no efficacy against gonorrhea. Now we go to CROI 2023. Oh, no. Beforehand, let's find out why the efficacy against gonorrhea is lower. Well, syphilis and chlamydia tend to find it too costly to develop resistance. In fact, syphilis is one of the few pathogens of any kind that you can still treat with old-fashioned 1950s style penicillin, and it usually works because they find it too costly to develop resistance. Whereas the gonorrhea bug is a very slippery bug indeed that finds it very easy to develop resistance. And that chart with all the nice colorful bars on the sides is all the different classes, not individual antibiotics, but all the different classes of antibiotics that this bug has burned its way through in the process of being treated ever since the 1940s. And the year, as it goes along, is the year the particular class of antibiotics was introduced, and the length of the bar is the number of years it took before highly resistant gonorrhea bugs started turning up. Okay, the orange bar with 2011 at the top, that corresponds to the drug ceftriaxone. Now that is still the main one that is being used against gonorrhea, because that was for a dose of 120 mg a day in an injection. They doubled that dose. Double dose ceftriaxone, 250 mils, is still the one that is mainly used against gonorrhea. In fact, it's just about the only one. You'll see a small amount of, if you go to 2020, which is the latest, which is the latest one there, then you'll see that the antibiotic gentamicin is being used by a very few, but that must be for highly drug-resistant gonorrhea, because gentamicin is not a nice drug. What this means is they effectively have one drug left to treat gonorrhea. There are other antibiotics being investigated right at the moment. There's one called, I'm looking at my notes, gepotidacin, which is in trials by ViiV, but it's a worrying situation. However, if you look back at the left-hand side of that diagram, you'll see a small thin blue line called tetracyclines. That's the class that doxy belongs to, doxycycline. and that stopped being used against gonorrhea in 1995. That means that the amount of drug-resistant gonorrhea that is in circulation has, to some extent, gone down against that particular drug family since then. Okay, so next slide, please. So this is the doxyvac study. If antibiotics don't reliably work against gonorrhea, will a vaccine? Because, as it happens, the gonorrhea bug is from the same family as meningitis B. And the vaccine against meningitis B is already known to have some efficacy versus gonorrhea. Okay. And they didn't think that the doxycycline would work against gonorrhea. This is partially because the background resistance in the French studies, about 56% of people at baseline had gonorrhea that was resistant to doxycycline, going up to 67% during the study. And that was rather less in the US study. So they thought it was unlikely doxypep would have efficacy against gonorrhea. So it designed as two separate studies in one, doxycycline versus the STIs in general, and vaccine versus no vaccine against gonorrhea. Next slide. That's just the title slide, right? This is the design. I've already kind of essentially told you what it is. The same people got two different medications. The doxypep was split 2-to-1 because we already knew it worked. So it was sort of felt to be a bit unethical to sort of split it 50-50. Let's go on to the results. Right, here we are. So, top left, doxycycline PEP. You'll see lots of these diagrams in this presentation. These are so-called Kaplan-Meier curves, which show you the incidence of infections. And the red line is the incidence of infections of chlamydia and syphilis on no PEP. And the blue line that's lower down is the incidence, the accumulated infections when they did take PEP. And so for syphilis and chlamydia, that was, again, excellent efficacy, 89% efficacy against chlamydia and 79% against syphilis. But if we go to the bottom right, you'll see that although the blue line is higher in this one, the red line is still clearly higher than that. So in other words, the doxypep somewhat unexpectedly did have some efficacy against gonorrhea. In fact, it had 51% efficacy, roughly cutting gonorrhea infections in half. Okay, so that's good news, really. And the vaccine was about as effective too. So very similar curve. The vaccine was 49% effective. So both the doxypep and the vaccine were about 50% effective against gonorrhea. They didn't interact. In other words, if you were likely, if doxypep was likely to work in you against gonorrhea, it doesn't mean that it would improve the chances of the vaccine working in you as well. It was quite independently. Responding to one didn't make it more likely to respond to the other. And also there was a suggestion, although this is not statistically very significant, that doxypep worked better against the anal and urethral infections and the vaccine better against ones in the throat. And that would be useful if it turns out to be true. But because of the way the trial was designed, we can't say that both together, 50% plus half of 50%, 75% would be the efficacy of both against gonorrhea. We can't say that, but we can speculate. Okay, on to another study. How much influence does doxypep have on gonorrhea resistance? Because this is the big worry with this idea that if you introduce doxycycline as preventative against gonorrhea specifically, it's going to hugely increase gonorrhea resistance and it's going to burn itself out. Well, this was in the previous American doxypep study, and they looked at resistance patterns in that. Excuse me, I need a drink. And the left-hand column is at baseline, the right-hand column is resistance seen after doxypep. Not much change there. Excuse me. But if we go on to the next slide, this is how resistance accumulated in the doxyvac study. And these are only the people who already had some degree of resistance against gonorrhea, which is why the bar is 100% to start off with. And you'll see that high-level resistance, which is the kind that means that doxy probably wouldn't work, does accumulate. But it also accumulates in the people who didn't take PEP. So that's a bit worrying, because it might mean that there's resistance starting to happen in the general population amongst the gay community, and is being reflected back into infections. Okay, next slide. And this is Roger.
Yes, so I will let...
I get over my cough. I apologise. I was explaining I've just had COVID, so I've got a bad throat. Okay, on you go.
All right, thanks, Gus. So, you know, as Gus has been explaining, there's now 3 large studies, all done with gay men, some mostly gay and bisexual men. I think one of the studies did involve some trans women as well, showing that doxypep is effective. So what a lot of science is now looking at is, well, how do you use this in the most appropriate way, and make sure it reaches the right number of people and use it most efficiently? So this is really an early study, just trying to make some quick assessments of what would be the best strategy for providing doxypep. So in this study, they assumed that doxypep was as effective as that previous American study showed, and they tried to look at how it would work if they used it in a place called Fenway Health, which is a really good center providing sexual health care and other healthcare primarily to LGBTQ plus people. They have quite a range of, there's an awful lot of cisgender gay men who use their services, quite a few trans women, non-people too. And so their analysis here focused on those populations, although I'm sure they do see some cis women as well, and some heterosexual men, they weren't included. And so they were trying to think about, well, who would you offer doxypep to? Those are the possible prescribing strategies they're thinking about there. So, you know, they could offer it to everybody who comes to their clinic. They could offer it just to people who are living with HIV and people who are using PrEP against HIV, making a kind of educated guess that some of those are some of the higher risk people, just PrEP users, or they could really focus it on people who've recently had an STI, on the basis that maybe giving doxypep for a year after you've had an STI might really target some high risk groups. Can we have the next slide, please? So these are the results. So what they're trying to look at is efficiency. So how many people do you need to offer doxypep to in order to prevent how many STIs? And they're assuming they offer it to people and every single person takes it, which is obviously unrealistic, but this kind of starts to give you an idea of where it might be useful to offer. So that bar on the top is, let's offer it to every single person who comes in to this clinic, which is a clinic a little bit like Dean Street, you could guess, in London. So you're offering it to 100% of people and you prevent 70% of STIs, but obviously that comes with a lot of cost, maybe some unnecessary prescribing, and you're more likely to increase resistance. And where it kind of gets more interesting is if you see, for example, a few rows down, there's one on any STI. So this is provide doxypep to anybody who has had an STI. So you're giving it to 41% of people, and they reckon you would then avoid 42% of STIs. And they think that's probably the most efficient strategy. You They could change a policy. So, for example, somebody who's had 2 STIs, you end up offering it to fewer people and prevent more STIs proportionally. But the real take-home message they were getting from this is focus on people with STIs, not, for example, on anybody with living with HIV or who's been using PrEP. Next slide, please. So they obviously did that study trying to think about guidelines. There's only one set of guidelines in the world that I'm aware of right now that does support doxypep, and these are from San Francisco. You can see what they say on the page there. San Francisco is one of the places that these studies have been done, so that might be one reason they're keen. But basically, they're saying that recommend doxypep to cis men and trans women who've had a bacterial STI in the past year, so very much in line with that last study, and who report condomless anal or oral sex with either a cis man or a trans woman in the past year. And just one little point we're going to come to in a second, look at point 3 there, where they're pointing out the lack of data for cisgender women. We're going to come back to this in a second. Next slide, please. Thought obviously we're in the UK. The last time there was any sort of document about this in some sort of semi-official document is a position statement from BASH, the Sexual Health Clinicians Association. Okay, so this dates from November 21, and I think it's really important to think about that date and when the evidence has come out. But this is an extremely cautious guideline. They very clearly say they do not endorse using doxypep or doxyprep, but they do recognize that many people are doing it anyway. People are doing it informally. People are buying the antibiotics online or elsewhere and using them themselves. So it's a bit like the early days of HIV PrEP, where clinicians probably have a role in trying to help people use them in an appropriate way. So, for example, one of the issues is, I think there's been some surveys where a lot of people thought they were using an antibiotic to prevent STIs, but they were using something else other than doxycycline. And there's no evidence that anything else would work. And that's where I'd hope a clinician could be helpful. So yeah, my guess is this looks like guidelines that need to be updated based on the latest information we've got. So next slide, please. So I mentioned the lack of data in women, and this is really a crying gap in the research until now. 3 large studies done with, again, bisexual men primarily, and none with women. However, there is a high burden of bacterial STIs in many parts of the world amongst women. There's quite a few long-term effects and risks with having STIs that are quite specific for women. You can see those on the right. Pelvic inflammatory disease, that's PID, most notably. And in an African context, cisgender women taking HIV PrEP have a very high incidence of chlamydia and gonorrhea. So a group of primarily American researchers working in Kenya did the first study of doxycycline PEP amongst cisgender women. Next slide, please. So it's a randomized study. It's the same dosing of the antibiotic as had been tested out with gay men. And the place it's being done is Kisumu in Kenya, where there is a very high, there's very high rates of STIs amongst young women, particularly young women taking HIV PrEP. And there's also quite a lot of resistance to gonorrhea in particular in this community, which is kind of relevant to what Gus was saying at the beginning. And I mean, you're going to see in a second, the results are disappointing. one thing, you know, in terms of the study design, they identified women who were already taking HIV PrEP, which might indicate that there's a certain level of desire to deal with sexual health risks or a certain level of concern. But it does seem that maybe adherence to doxypep was a problem here. Next slide, please. So these are the results. I mean, basically, looking at that graph with the blue and red lines, and they're exactly on top of each other. Gus showed you some similar slides, graphs earlier, where there was quite clear separation, which was showing that doxypep really made a difference. And here, it really did not. There's just no sign of efficacy. So next slide, please. Why is that? Now, here's where the technology is hopefully going to work. Here's an interview with the lead researcher on this study, where I basically asked that question. Are we not getting any sound?
No.
No. Okay.
We good.
Right. Okay. I better continue then. I mean, she's much more articulate than I am, and that's why I wanted to put the video in. But what she basically says is there's three things to look at. And the first one is adherence. And it's...
I'm just going to try again, Roger, because I was on mute, so might be that might be why.
Actually, there are subtitles, so let's leave it. All right, sorry for not having the sound on that, but I hope you got the main message. So that was the end of the information we wanted to present on doxypep. So it would be really interesting to hear people's comments and questions.
Just have a look at the Q&A. I cannot see any questions at the moment. Now's the time to ask them. Nicola, I don't know if you can see any.
No, I can't see any, but I actually had a quick question that maybe I could ask while while we're waiting for some to come through the Q&A. Is there any indication or evidence for people who are like self-sourcing doxy to use doxypep themselves, is there any evidence to suggest that they are testing less? Because maybe if there's an assumption that they don't have any STIs because they're using this doxypep method, is there any kind of research into that?
I'm not aware of any, and it might work the other way, that if you are using doxypep, you might be more anxious about STIs and you might test more. So I don't know. I don't think, I haven't seen any studies suggesting that.
No, me neither. Me neither. But yeah, that would be interesting thing to ask. Yeah.
Got some questions coming in now. So hold on, I'll go by first serve. So the first question was, what monitoring beyond routine STI screening would you offer to people who are self-sourcing doxypep?
Well, obviously you need to know exactly kind of what regimen they've been taking it on and things like that. I do know that there's quite a bit of self-sourcing around. First message would be, don't use any other antibiotic, because as my resistance chart should have said, you know, penicillin, it's not going to work, not against gonorrhea anyway. No, I think probably if you try doxypep and you still have a nasty case of gonorrhea, then they might be interested in testing you for resistance. But I think if you have gonorrhea, you should be going straight to the clinic and getting a ceftriaxone injection anyway. You shouldn't be messing about with doxypep. It's basically, if you stay with the other two, it's with chlamydia, it's slightly more difficult because most chlamydia infections in men, it has to be said, are asymptomatic. The majority are. And so you wouldn't necessarily know whether you got it or not. So I would still recommend, whether you take doxypep or not, testing regularly for STIs if you're somebody who's at risk of them.
And I think maybe the other really key thing that clinicians could do for someone who's self-sourcing it is maybe just checking that there is an understanding of when to take it and what the situations in which you should take it are. And for for any cisgender women to be clear about what the evidence is so far, and particularly there is a safety concern about using it during pregnancy, and that would obviously need to be shared by anyone who can get pregnant.
And really just to underline that it is not a treatment. So if you already have symptoms, go to the clinic.
Okay, next question. Was there any data on uptake after being offered doxypep or acceptability more generally?
Not yet, because these are studies. It hasn't really been rolled out systematically, as far as I know. If there is data from San Francisco, I'm not aware of it. Roger?
Yeah, I mean, I think maybe the only thing to reflect on is, as far as I'm aware, there weren't really any issues or concerns in those studies with gay men in France and the US about uptake and adherence. Like amongst people who enrolled in the trial, it seemed that they were using the antibiotics as they'd been suggested to, whereas it seems that was not the case in the study with women in Kenya. So maybe there's some clues in there, but yeah.
Okay, next question. Should we be sticking with the BASH guidelines, or should we be promoting doxypep for higher risk individuals?
You wouldn't let go of that on me. There's a little saying of things being beyond my pay grade. I think that is very much up to a large body of extremely well-informed doctors, such as BASH, to make up their minds, though I might be perfectly interested in being the patient rep on such a body. But I certainly wouldn't, you know, there are so many things to take into account. I'm not going to. I don't know.
I might go. I might go a bit further than that and say, when you've got 3 well-conducted phase 3 clinical trials in very similar populations, all showing some effectiveness, definitely against chlamydia and syphilis, and in some of them against gonorrhea. We need to have guidelines for that kind of population on using that approach. I mean, those studies so far, okay, the unanswered question to some extent is resistance, and that is a public health question. So, you know, individuals using this may possibly contribute to more spread of resistant strains, though that data from the States was pretty encouraging, though it's quite early days. So that is something I would expect people who understand these issues better to take into account. But it does feel like that 2021 guidance or position statement is overly cautious given what we know today.
We also need at least one more study of the vaccine, because if that proves to be at least 50% effective, then that needs to be taken into consideration too. And also it's important to note this was not a vaccine designed for gonorrhea. It's designed a bit like the monkeypox vaccine. It was designed against a related bug. If that proves to work, then scientists could have a go at redesigning the meningitis vaccine to work better against gonorrhea.
Okay, I've got two more questions and then we'll move on for the sake of time. But if there are more questions, we'll get to them at the end. So if doxyprep is used, what is the dose and how long would it be taken for?
Off the top of my head, I think it's 250 mg. And basically, you take one dose every time you've had a likely exposure to STI, or in other words, in the same way as you might do for HIV, but afterwards. And one should be enough. It's not, you don't have to take 2, 1, 1 or something like that. As long as one is taken within, I would say 24 hours, then it should have the efficacies we see in the studies.
Okay, and the last question was, if you know, how was doxypep prescribed for 12 months and what kind of supply was given?
I don't.
I mean, my guess would be, I think people definitely had it in hand. People didn't need to go and see a clinician at that stage, but maybe it was giving a month's 30 doses and asking people to come back when they had a concern. I genuinely, I'm guessing there.
We've got one more question just come in. Sorry, we'll squeeze it in. So as we know, individuals are going to do what they want to do. What does the harm reduction narrative suggest here?
Well, it's the same debate to some extent as around PrEP, but there it was much more about kind of, well, that increased risk behavior. It's not so much that here. It's more about a medical question of will it actually introduce more resistance against gonorrhea. And I think the important thing to know about doxycycline is that it is a different kind of antibiotic to the one that's generally used currently against gonorrhea. So I think in terms of bringing in sort of untreatable gonorrhea into the community, that is not the issue. The issue is much more about whether when they have symptomatic gonorrhea, people get the appropriate treatment.
And I'd also just say, it strikes me there's a lot of people that are quite wanting to do something to look after their own health and take action on it, and they're aware of the harm of the infection. And yeah, nothing comes without risks, but it strikes me we need to find ways to support people to look after their own health like this. Okay, are we going to
Q&A? Yep, that's all the questions done. So if we move on, I'll just pass the Q&A slide. We've done that. So yeah, carry on.
Okay, so I'm going to pick up a few bits. There was some really important data presented on mpox, and obviously, to some extent, I think lots of people we can sort of think about. It's easy to think mpox is last year's story, and hopefully, it is just last year's story. And it's not going to come back, but we're only really just now learning about some of the aspects of what happened last year. And obviously, if it ever does come back in larger numbers, or just become a sort of low-level problem in the background, some of these things we really need to know about. And this was actually really some quite disturbing points about the impact of Mpox on people with low CD4 counts. So, as lots of you know, in Mpox last year, up to half the cases in a lot of countries were in people living with HIV. Most of those people had well-controlled HIV, and they did okay. It was not a pleasant disease, but the disease was not worse for people with controlled HIV than it was for people who are HIV negative. But we're now realizing that there is an issue for people with lower CD4 counts. So, led by Chloe Orkin, who is a clinician based in London, researchers gathered data from 19 countries all around the world on specifically just trying to get specific details of patients who had a CD4 count below 350 and had both Mpox and HIV. Next slide, please. Can we advance the slides? Cool, thank you. So they got data on close to 400 people in line with the epidemic. Vast majority were cisgender men and I assume mostly gay men. And there were, about a third who had been knew they had HIV, but had either stopped taking antiretroviral therapy or were having very, very inconsistent adherence to the therapy. And there were 9% of these cases were people who were only diagnosed with HIV when they were getting clinical care for their monkeypox. And so the study is only looking at people with lower CD4. But a lot of these people had really extremely low CD4 counts. So anything below 200 is typically described as advanced HIV or AIDS. And obviously close to half of this cohort have CD4 counts at that level. And not many people were vaccinated against Mpox. Next slide. So to talk you through, this is one of the slides from the presentation. So those bars are the CD4 counts. And actually, let's look at the one on the right at the beginning. The big purple blob is marked on the legend OPD, and that is about outpatient care. So people with CD4 count basically above 200 were almost all treated as outpatients. They didn't have to go into hospital, and most of their cases was resolved in time. There's the sort of turquoise blob at the top of that bar, which means that they were hospitalized. Then let's move on a bit to the left. So the one that is 101 to 200, so the second one from the left. Again, most people still treated as outpatient, lots of people as inpatient, but there is a small group there who were in ICU, in intensive care, which gives you a sense of the severity. And there were also deaths, the sort of orangey layer at the top. And then the really disturbing one is one at the left, so people with CD4 counts below 100. So let me check, get the number of deaths there. Yeah, that's 27% of people who had a CD4 count below 100 and had both HIV and monkeypox and Mpox died, which I think is a really quite shocking finding, and then substantial numbers also needing intensive care and inpatient care. So there were quite a few deaths in this study, none in people above with a CD4 count above 200. And also, by the way, none in people who were vaccinated against Mpox. But yeah, these findings did quite surprise the researchers. Next slide, please. so this is from their conclusion slide, and pointing out the mortality, which I've just mentioned, and also the clinical manifestations of the disease were really quite shocking and quite unpleasant in many people. And they're arguing that Mpox should be considered in people who have such a low CD4 count, like below 200, as an AIDS-defining condition, that it's behaving in the same way as other AIDS-defining conditions in somebody who is very immunocompromised. Next slide, please. So some of the, well, one clinical implication, I think one implication for us, which is not there, is about people who remain undiagnosed, and about the importance of getting people diagnosed with HIV, because clearly the longer you're left undiagnosed, the greater the risk of immune system being depleted so much. And there's some also quite specific things about how clinicians should manage this, about when to start ART, and to make sure that people get access to antiviral treatment for Mpox, which in many of the, particularly the Latin American countries in the study, that didn't always happen. Next slide, please. This moving on. This was just something that I think may be changing the way that care is provided in the next few years. There's work on being able to test people taking HIV treatment on their adherence using a urine test. So something like it's similar to a pregnancy test. And the idea is that this can quickly give an instant read on whether someone's got the drug in their body, and that can actually guide the way that people's care is provided. So I think it shouldn't really be a thing about surveillance, but more about working out when people need more support on this. Just to read through what those numbers mean on that slide. So 91% of the people who had a kind of considered a high level or a sort of acceptable level of having the drug tenofovir in their body, so were virally suppressed when that was tested in another way. So that means that usually most people who appear to be adherent are also virally suppressed, whereas the negative predictive value, 63%, what that means is that 63% of the people who, where the test said you don't have the drug in your body, they had a detectable viral load. In other words, the majority, but by no means all people who get a negative result on this test, there is definitely a problem that needs investigating. Next slide, please. And a couple of things on injectable antiretroviral treatment, which, as you know, is coming up. The studies that have been done on this were very much designed for people who were already doing okay on daily pills, and then were switched to injections. And to some extent, this is the drug company and the researchers going for the low-hanging fruit. So this is perhaps the easiest group to show that they work for. But as I think there's lots of anecdotal evidence that the people who really need an alternative to daily pills are precisely the people for whom daily pills have not been working. And so this is some data from San Francisco, where they are trying a program where they're working outside of what they're officially meant to do. They're providing the drugs off-label to people who've had problems with adherence in the past. They're giving them an awful lot of extra support, and perhaps some of that support we could expect to find in the UK, but in the US is actually quite exceptional. And this is showing that many people are able to get good results on these injections in this situation. And next slide, please. Slightly different point about the same drugs. So you need a lot of this drug to get into a muscle for them to work. Been designed to be injected into the buttocks. And given where they're injected, that needs to be done by a healthcare professional, so people who can't self-inject. So there is interest in trying to find an alternative. And so the thighs is something that's being worked on. And this is some fairly promising data showing, when that's been tested out, very similar drug levels between the thighs and the buttocks. People do kind of get these, what they call injection site reactions, which can be pain, can be swelling, hardness. So that is quite common. And there was a real mix of whether people preferred having the injection in the buttocks as they used to do, or this new thing in the thighs. And I think it's about personal preference. Okay, I've sped through this bit because I'm aware of time, and I'll now pass over to Gus.
Yes, and I'll skip some of these as well. Okay, so injectable PrEP, where sort of people's difficulty with adherence is very much part of why injectable PrEP is a really great idea, I think. And really just sort of updates on the two studies, HPTN-083 amongst gay men and trans women, and HPTN-084 amongst cisgender women in Africa, which were reported several years ago, really. I'm not really going to say any more about HPTN-083. The open label continuation of the study continues to show that cabotegravir prevents 66% more infections than oral PrEP does. That's the important point to make. So in terms of, if it was related, if it was put against no PrEP at all, it would be even more effective. And the basically adherence to the oral PrEP was about 66% as well, which suggests that if you gave cabotegravir injections in a population that didn't otherwise have PrEP, it would stop about 90% of HIV infections. This is in gay men. But let's move on to the women's study. I don't need to go through this. This is just about the handful of infections that broke through. Okay, so this is HPTN-084, and this, I think, was an extraordinary result. The most effective, I mean, the highest efficacy seen in any trial of PrEP. And contrary to what we've tended to see with women in the past, they've always done badly in trials of PrEP. Nearly all, not all, nearly all, but a large majority of the trials of PrEP produced difficult results for women, partially because, for one reason or another, adherence often seems to be low. And we saw that again in the Kenyan doxy-PEP study. That was part of the story. But if you see on the top right, which is the infections seen in HPTN-084, there are hardly any on cabotegravir. That's remarkable. It's the green line right at the bottom, which is difficult to see. One reason was because, again, as we've seen in other PrEP studies, adherence to oral PrEP was low in women. These bars, the blue bars, are adherence in men in HPTN-083. And as you go towards the right, you have higher adherence. So most of the gay men in HPTN-083 and cisgender women took adequate levels of PrEP, whereas the red bars are adherence to oral PrEP in women in HPTN-084, and the majority of them didn't take enough. Add to this the fact that women seem to require biologically higher levels of tenofovir in order for PrEP to work. And you have the same picture you had in a lot of other PrEP studies. This just doesn't work, whereas the injections very clearly did work and worked extremely well. So this really does suggest that injectable PrEP is the way forward for women, I think. Next slide. And there may be a reason for this. For once, biology may be on the side of women. This is a complex slide, but basically what it says is that cabotegravir was given every 2 months after the initial injection, which was once a month, had a month between them in women. But if women delayed, and there were obviously sort of women who, for one reason or another, came in late for their injections, they still had perfectly adequate levels, even if there was a 3-month gap between injections. In fact, even if there was a 4-month gap. So this suggests that quarterly dosing, quarterly injections should be enough to work, which would be great because that tends to coincide with the gap that's already there in injections of contraceptives, which are used quite widely in Africa, for instance. So that's good news, I think, for women and people who are suggesting that injectable PrEP is the way forward for women. How are we doing on that? Let's go to the next slide. Okay. Slowly, I think, is the answer. Long-acting injectable PrEP was approved by the US in December 2021 and recommended for HIV prevention by WHO in July 2022. But in Europe, marketing application was only accepted by the European Medicines Agency in October 2022. That means the first stage. They haven't given an opinion on it yet. And they haven't even yet applied to UK's equivalent, the MHRA. This is due to Brexit. The US, Australia, Zimbabwe, South Africa, and Malawi have now licensed injectable cabotegravir as PrEP, but that doesn't mean that it's available. And MSF are also planning demonstration projects in Mozambique and Eswatini. MSF being the Médecins Sans Frontières, Doctors Without Borders, the big NGO. ViiV, the manufacturers of injectable cabotegravir, announced the generic companies that they would be working with to produce injectable PrEP on license at the end of last month. But according to MSF, that may take a considerable time for the generic companies to develop the capacity because manufacturing is more complex than it is for pills. And of course, behind all this, the issue is price. Cost-effectiveness studies find even in the US, injectable PrEP can't cost more than $3,000 more than generic Truvada to be cost-effective. And in South Africa, it can't cost more than about $90 to $115 a year, which is like kind of not much more than the minimum price they've managed to knock down to for antiretroviral therapy. So I think we have a long way to go. And this very, very briefly, this is a treatment study, but it includes a drug called lenacapavir, which is the next big hope for injectable PrEP as well. Lenacapavir is a unique HIV drug with a different mechanism of action. It's a capsid inhibitor. You don't need to know what that is. That's what it shows you in the diagram. And this was given alongside 2 broadly neutralizing antibodies, which you may also have heard of. These antibodies that turn up in highly treatment experienced people, which they are now using as prevention drugs. These have completely unpronounceable names, but which are rather nicely called TAB and ZAB, these 2 different ones, but they gave them together because HIV does find it quite easy to develop resistance to neutralizing antibodies. So they need to be given together. And all 3 were given as 6 monthly. So that's only twice a year. The broadly neutralizing antibodies by a drip, an infusion, and lenacapavir as a subcutaneous injection. You could put it in your tummy. It's probably much more easy to do. It could be done by a less trained medical person or even self-administered. Next slide. No, I don't need to know the design. Next slide. And you don't need to know that either. They were moderately treatment experienced people, but it was only 10 in each branch. So this 10 in each arm. So this is an introductory study, and nearly everybody maintained undetectable viral loads. 1 person dropped out. That's the purple square. But 1 person did rather puzzlingly fail to respond. They did bounce back. Their viral load only went up to about 250, but even so, that was counted as a rebound, and they were put back on ordinary antiretroviral therapy. Next slide. And there is a puzzle here because this shows the levels of TAB and ZAB, our 2 antibodies, and the lenacapavir in everybody in the study. And as you can see, even after 26 weeks, in other words, 6 months, the levels are still way above what should be adequate to prevent HIV. And the red line is the levels in the person who rebounded, and they were fine. In fact, they were even higher than average when it comes to lenacapavir. So we don't know why they rebounded. This is a very early study. We will probably be getting answers later on, but lenacapavir is very promising. And it is currently being studied in 2 big trials as PrEP, and they are called the PROMISE studies. PROMISE 1 and 2, a bit like HPT and 083 and 084, 1 in gay and bisexual men, 1 in cisgender women in Africa, and there are also a couple more studies coming along. So that's all the slides we got.
Great. I'll just have now's another time to raise questions if you have any. Please put them in the Q&A box. There's none as yet.
I've also just popped a link in the chat, which is some feedback. So if you've got a couple of minutes to spare, we'd really appreciate just filling in a quick bit of feedback using that link.
There's no questions as yet. Give it a couple more minute or two.
I can do a bit of feedback as well. We've just done, if I may put evidence brief on PrEP in women, and that actually provided quite a lot, because I when did it, that provided quite a lot of the sort of background information on how well or not well PrEP has worked for women. And if you look at that up on aidsmap, you can take a look at that as well. There's a lot of background info there. Brilliant.
Well, there's no questions, so I think we'll call it a day there. Just to reiterate again that the slides and the recording will be made available to everybody afterwards. If you do have any more questions, feel free to drop myself, Nicola, an email, and we'll pass it on to Roger and Gus, who can answer any more questions. But thank you for everybody's time, and thank you for coming, and see you all again soon.
Thank you.
Thank you.